All right, ladies and gentlemen, this is Chapter 7, Perinatal Infections. It's interesting, many obstetrical perinatal infections are contagious, and you can see here, looks like both the male and the female got it. We will start with Group B beta hemolytic strep, Group B Streptococci. Here's our case. And I want you to notice these cases. I wrote these cases specifically to bring and incorporate in the key elements that you should know for the Step 2 exam. And this patient particularly incorporates the risk factors for Group B strep. A 20-year-old gravid 2 para 1 is admitted to the birthing unit at 35 weeks in active labor at 6 centimeters dilated. The first thing I want you to notice, she is preterm. One of the risk factors for Group B strep sepsis of the newborn is prematurity. Her prenatal course, first trimester positive Group B strep urine culture. A second risk factor for Group B strep neonatal sepsis is positive maternal Group B strep urine culture. Her first baby was hospitalized for 10 days after delivery for Group B strep pneumonia, previous baby that was affected. This woman is very high risk for her current baby to get neonatal sepsis. Group B strep sepsis is a big concern because there's 50% mortality. Now, 30% of normal women of reproductive age will have in their vaginas Group B streptococcus. This is not an infection, this is a colonization. This is important to realize because just because you get a positive Group B strep vaginal culture, it does not mean that you treat it. And I think that we have a long ways to go in realizing that the presence of bacteria does not mean infection. And we have overused antibiotics, I think, in our country, and with the result of many resistant organisms. So do not treat a positive GBS culture in the mom. All right, if a mom has GBS in her lower genital tract, what is the transmission rate to the neonate? 50%. Are these babies infected? No, they are not infected. This is colonization, not infection, and that's an important distinction. Okay, the attack rate for Group B strep sepsis in the neonate is what we're really concerned about with, and that is far less common, 0.2%. That is 2 per 1,000 babies. Now, why are we so concerned about it? The reason is the mortality rate with early onset Group B strep sepsis is 50%. Half of these babies will die. And that is too many. And that's why we go through all of the efforts that we do to prevent it. Clinical findings of early onset Group B strep sepsis is pneumonia. Here we have the case. We have a woman who has a normal prenatal course. She has no complications. She comes in labor, normal fetal heart rate tracing. Baby's delivered without any problems. APGAR scores are 8 and 9. However, within a couple of hours of birth, bash, the baby crashes. And you get a chest x-ray, and what do you see? Whiteout. Total whiteout. Do these babies get fever? No. What they do is they get hypotension. And half of these babies will die. Pneumonia and sepsis is the findings with early onset Group B strep sepsis. How do we prevent it? The antibiotic of choice is penicillin G. And remember, we are prophylacting these patients. Okay, let's move on. Newborn sepsis, within hours of birth, bilateral diffuse pneumonia, your most likely diagnosis, Group B strep neonatal sepsis. All right, what are we going to do to prevent this? We're going to give penicillin, and Group B strep is exquisitely susceptible to penicillin G. We're going to divide the patients that we're going to give prophylaxis, the moms in labor, into 3 groups. The first group, we're going to give prophylaxis without screening. We're not going to do the 36-week vaginal cultures. Why? Because the risk is so high, we're going to go ahead and give prophylaxis anyway. If she had a positive urine group B strep culture, anytime during the pregnancy, or if she had a previous baby with neonatal sepsis. And remember the case that we just went over? This mom had a previous affected baby, so she will get prophylaxis without screening. Most of the patients that we see are going to have a 3rd trimester vaginal culture. And remember, this is not a cervical culture, this is a vaginal culture. If it is positive, we will give prophylaxis to the mom in labor. If it is negative, we will not. What if a patient comes in without any prenatal care, has never had a 3rd trimester vaginal culture? Then we will prophylax based upon risk factors. And those are, if she is preterm, less than 37 weeks gestation, if the mom has ruptured membranes for 18 hours or more, or if mom has intrapartum fever, then we will give penicillin G prophylaxis. So these will be the criteria on which we will give prophylaxis of penicillin G in labor to the baby. This article looks at how rapidly the colony count of group B strep drops after giving 5 million units of pen G in labor. Within 2 hours, 80% reduction. Within 6 hours, 99% reduction in the group B strep colony count. So very, very effective. This looks at the prevalence of group B strep sepsis over time from when the initial recommendations were made. You can see that we start out with about 1 to 2 per 1,000 infection rate, and we end up with about 0.5%. So we've reduced the incidence of group B strep sepsis by 2/3. Very effective. There is now development of a group B strep rapid test, which uses a DNA probe, which can then within a matter of minutes, if not an hour, give you the results. And this can be very helpful, particularly if you have absence of prenatal care. And that's the end of our section on group B strep.